Hi, everyone. Thank you for attending today's webinar on advocating for residents with mental health needs and what to do when a resident threatens to harm themselves. My name is Katie Kohler, and I am the Program and Outreach Associate with the National Ombudsman Resource Center. Today, we have three excellent presenters. Dr. Patrick Arbour is a nationally recognized expert in the field of elderly suicide, prevention, and grief services. He has devoted his life to increasing awareness of isolation, loneliness, and depression in older adults. Dr. Arbour will share warning signs, ways to promote better informed and healthier communities, and resources and supports for ombudsmen and residents suffering from inner loneliness, sorrow, stress, and anxiety. Following Dr. Arbour's presentation, Jamie Freshy, the Illinois State Long-Term Care Ombudsman, will share her program's policies, procedures, and tool that guides the program in responding to residents that talk about committing suicide. The webinar will conclude with a presentation from Natasha Belli, an Illinois program representative, who will share her experience working with a resident that threatened suicide and the steps she took to support the resident. I'm sorry, I'm just trying to hit the next slide. It is not working. I wanted to go over a few housekeeping announcements before we begin. You can use the red arrow to expand or collapse your control panel. On this panel, you will see audio options, but at this time, all lines have been muted. If you have any questions, please enter them in the box on the side panel, and Amity will facilitate a question and answer section at the end of the webinar. The recording of this webinar will be emailed to everyone that registered and will be posted to our website shortly after. I wanted to begin this webinar with two polls. The first poll asks if you have encountered a resident that has threatened suicide. So I'm just going to give everyone a minute to vote. So we are just trying to gain an understanding of how often this may happen and the comfort level of Ombudsman Program representatives that encounter a resident with mental illness or are threatening to harm themselves. Okay, I'm just going to close this. It looks like most people have voted. 54% of you said yes, and 46% said no. So we have a little bit of mixed responses. And then the second question that I wanted to ask is, what is your comfort level in handling a situation when a resident threatens to harm themselves or commit suicide? I'm just going to give everyone another minute to answer. Okay. 29% said not comfortable at all, and 61% said somewhat comfortable, and 10% said very comfortable. So excellent, thank you. So we're going to ask this question again at the end of the webinar. So at this time, I would like to turn it over to Dr. Arbour.
Thank you very much, Katie, and I'm very happy to participate in this webinar. And I know I might have met some of the participants in various parts of the country, as I give a lot of talks throughout the country. And so I want to say hello to them and also say hello to all the people I have not met before. And I'm very, happy to be here and to talk about these issues related to suicide and suicidal ideation among older people. And I know Katie's going to forward the slides for me, so please do. And I am the founder and the director of the Center for Elderly Suicide Prevention and Grief-Related Services. We began 45 years ago in 1973 in response at that time to the high rates of suicide among older people. And what we were aware of back then was that with the high rates of suicide, the thinking was traditional suicide prevention centers would show, a comparable numbers of calls, that there should be, calls of people who are older wanting to reach out and talk about, their feelings or thoughts, and that wasn't being reflected in the data of traditional suicide prevention centers. So we were tasked with the mandate to try to come up with another way to reach out to older people, to that particular population. And as many of you know, certainly because of the holidays, you've probably spent time with older family members, parents, grandparents, other older aunts, uncles, that people like that. And if you begin a conversation with them that has to do with a confrontation, saying to your parents, hey, we really need to do end of life planning, you haven't written a will, that sort of thing, or mom, dad, grandmother, you might have to downsize, that sort of thing. And older people tend to dig their heels in, and they don't want to respond to that. The confrontation makes them feel defensive, and they become resistant. And we were aware of that with answering a traditional suicide prevention line, hello, suicide prevention, and that a lot of people would just hang up, and we felt that those people were probably older ones. So we decided instead to have a conversation rather than a confrontation with older people, and we decided to call our program Friendship Line, and you see that number on the screen. And we began locally here in the Bay Area, San Francisco Bay Area, and we have certainly expanded over the years to the whole country. Back in 1973, for example, if we had 50 contacts with older people, I thought that was pretty good. Last month, in the month of October, we had something like 14,000 calls in the month of October. And we estimate that this fiscal year will probably be serving over 170,000 calls. So we're aware that the friendship line is how we answer the lines, really made a difference. Rather than hello suicide prevention, we say hello friendship line, this is Patrick, how may I help you? And that has really proven to have been a good strategy. People don't have to be in a suicidal crisis to call us, and that is part of our warm line component. We're accredited by the American Association of Suicidology, and we're the only, as far as I know, accredited crisis intervention hotline, warm line, that really targets older people. Katie? And so I want to introduce just issues related to older people about mental illness. And, as we go through this, I'm not going to go in detail about every slide, but I wanted you to have these slides because I think they will be, a useful resource for you in your work. And, mental illness, as most of us are probably aware of, is a term used for a group of mental conditions that can cause severe disturbances in thinking, behavior, feeling, and relating, often resulting in a diminished capacity to cope with the ordinary demands of life and distress. And mental illness can affect persons of any age and social strata and can occur in any family. Next slide. And older adults also experience many challenges and adjustments, just in terms of aging. And good mental health enables a person to face these challenges and deal with them. And unfortunately, many older people believe the myth that mental health problems result from personal failure or weaknesses. This stigma, which has been around since I began the program back in 1973, which is, if I would say to an older person, it sounds like you have symptoms that are representative of depression, and maybe we could talk about that. And back then they would say, "Oh, you think I'm crazy, and I'm not crazy," and this sort of thing. And sadly and unfortunately, that is still happening today, and this is 2018, and it's and I think it's in part due to the fact now that depression is a term that just gets volleyed about. If we have a bad day or if we didn't have plans on Friday, that people say, "Oh, I'm so depressed," and I think that we've kind of altered and distorted the truth of that term, which is it's really a clinical term, and it's something that is very important, but it's not a synonym for aging. Next slide, Katie. And so what are some of the common mental health issues? Well, we focus a lot on the mental health of younger people, but it's also very important that we look at older people. And one of the things that we certainly see on the friendship line is out of those thousands of calls we get, uh, we can hear older people, describe their symptoms. They're not able to sleep, or they're not eating properly, or they've withdrawn. And yet, when we ask them, if you have been, has your primary care physician talked about depression? Have you seen a counselor? The answer is often no. And so it's very hard to treat someone for a condition that no one recognizes. And that's a problem. And depression can complicate, and the reason we want to be more aware of these is because it can complicate other physical conditions, certainly stroke, diabetes, heart disease, and others. And depression is a mood disorder that ranks as the most pervasive mental health concern among older people. And again, if it's untreated, it can complicate other health conditions of that older person, and can get in the way of social functioning. And that really was the pillar upon which Friendship Line was built. Was that we knew if we could decrease loneliness and social isolation, that could have a positive impact on depression and or suicidal behavior. Next slide, please. And so, again, physical health and mental health are very interconnected. And health problems can also lead to depression, and depression can also lead to health problems. And so what we want to notice with older people, really, I think from your perspective in terms of the residents in which you serve these seniors, that any change of behavior is something that you want to note. If it looks like this older person had previously always been involved in activities in the residence, and then, fairly suddenly just stops attending or participating, there's something going on. And studies have shown many older adults with depression spend as much as 3 times the amount of money on physical health care as those without depression. And so what that implies is that older people will talk about their arthritis or their, pains, joints, that sort of thing, and that they're not very good at developing a vocabulary for mental health issues. Next slide. So, anxiety is another disorder that is frequently experienced by older people as well, and it's very common. And statistics from the Centers for Disease Control show that nearly half of all older adults with anxiety also experience depression. And so depression and anxiety can coexist. Anxiety in seniors is thought to be, again, underdiagnosed because older adults tend to talk about their physical problems and really just seem to lack a vocabulary for, psychological issues. And women in the older ages are more likely to be diagnosed with anxiety disorder than men. Next slide. And so, what are some of the risk factors for anxiety? Again, just general feelings of poor health. And I highlighted sleeping problems because that's an area that can really cause tremendous problems with older people. And we see more and more literature about the importance of having disrupted sleep and how that negatively impacts the overall health of older people. And and that's something I would also just advise us to be very aware of older people who are, falling asleep during the day at activities or whatever, and are not sleeping very well at night, and that can contribute to a whole host of problems. Next slide. And so, what are some of the risk factors in addition to the ones I was just mentioning? Again, our physical impairments that affect our activities of daily living, stressful events, certainly bereavement, loss of a spouse, medical conditions, when people are diagnosed with a really challenging physical health problem, or their spouse or partner or loved one, can be very, very disturbing for older people. And trauma in childhood can also be a factor when it comes to mental health issues, including suicidal ideation. Early traumatic issues that were never processed, never dealt with, often go underground while a person is busy raising children or working or whatever. And then in their later years, this trauma comes back up. And then what happens often too is this perseveration on physical symptoms, that we really just focus on, my heart, my hip, my whatever. And older people can get very distracted by that. Next slide. And so, warning signs for anxiety really is worry. And many of you might have had parents, like I had a mother, who would say, I worry so much, and that's because I really care about you. And that type of justification is really just so unhealthy for older people. And yet they see that as a badge of honor, that I'll stay up all night worrying about a grandson or an adult child, as a way of saying, look at how much I care for you, while at the same time they're causing problems with their health. And again, poor quality of sleep or difficulty falling or staying asleep is another warning sign for anxiety. Next slide. And then I did, mention trauma. And again, it's exactly as I was saying, that it can go dormant and then reappear in later years. Next slide. And so, how do we know that a older person might be suffering from trauma? Well, they experience emotional numbness. That they're very lacking in flexibility when it comes to emotional feelings. They'll have flashbacks to events that happened years ago, nightmares, depression, irritability, distracted, startled, angry, frustrated. Next slide. And so, despite what we've been talking about in terms of this information and how older people are very susceptible to feelings of depression or anxiety or trauma, it can be difficult to pick up on mental health issues among older people because of the unique age-related health and life challenges. And sometimes symptoms can be very subtle or attributed to a variety of health conditions or life changes. And again, what this requires us to really notice is, who is that older person for whom I care at my facility? And do I know them well enough to notice changes in their behavior, in their feelings, in their mood? Next slide, please. And one major problem in diagnosing and treating seniors with mental illness is that elderly individuals are more likely to report physical problems, as I said, rather than discussing depression or anxiety. Next slide, please. And so, as we are people who care for older people, the best thing we can do is understand the symptoms and risks associated with these mental health problems, which can, if they're not treated, as we know with depression, one of the criteria is recurrent thoughts of death and or suicidal ideation. And so depression is frequently looked at as one of the biggest risk factors for suicide. And we want to really nip that in the bud. We want to really be able to help people get the support that they need or the treatment they need so that they don't slip into a suicidal crisis. Next slide. And so some of the triggers for mental illness, according to the National Institute of Mental Health, again, chronic pain, chronic disease, which certainly affects older people much more than it does younger people. Physical disabilities, loneliness, as Katie mentioned earlier, major life changes that I have to move from my home where I lived for 50 years, and now I have to move into an assisted living, and there might be a lot of grief attached to that. Bereavement, medications that can also trigger feelings of depression. Alcohol consumption is still referred to as a hidden epidemic in the lives of older people, malnutrition, or memory loss, cognitive impairment. Next slide. And if you're working with older people or have a loved one in your life who's older, you can spot these indicators of mental health issues. And again, just paying attention to changes in appetite or energy level, which are, again, symptoms for depression, feeling emotionally flat, sleeping too much or not getting enough sleep, thoughts of hopelessness, sadness, and then, of course, definitely suicidal thoughts. Next slide. A desire or need for drugs or alcohol. So we see older people who might be misusing prescribed medication and or drinking, short-term or recent memory loss where they're just not functioning, and that might be as a result of the medication or it might be a result of disrupted sleep. Difficulty managing finances, problems with hygiene, can all be things that we want to pay attention to in terms of warning signs. Next slide. So what we must do is that we must recognize that a mentally ill person in crisis may be overwhelmed by sensations or thoughts or frightening beliefs or hallucinations. And this is especially important with people who are not sleeping properly. And there's a myth out there that older people don't need as much sleep as younger people, and it's a myth. Older people also need the right amount of sleep, which is usually around an average of, 8 hours a night. Next slide. So I just want to introduce the topic of suicide, and that, as we know, with the deaths of Anthony Bourdain and Kate Spade, which was just within this past year, I think Anthony Bourdain was something like 64. Kate Spade was in her middle or late 50s. Also, 5 years ago was the death of Robin Williams at 63. And what newscasters were finally able to start to realize is that our suicide rates are increasing. And this is especially of concern for us in human services, social services, but also law enforcement. And we see that daily there's usually around 80 to 90 deaths by suicide in the U.S. In 2002, for example, total number of suicides for people of all ages was around 31,000. In 2016, according to the American Association of Suicidology, there was something like almost 45,000. And what we're seeing is that these deaths by suicide are increasing in every age category. Suicidal persons pose a substantial risk to everyone involved in the crisis, their family members, neighbors. This is something we need to pay attention to. Next slide, please. So the rate of suicide for the elderly is one of the highest among adults compared to any other age group. We're seeing now that 45 to 64-year-old group also has had a spike in the numbers and also rates for those individuals. And the suicide rates for people 85 plus and older is really the highest of all. It's twice the overall national rate. And what is disconcerting about this, as I think we probably all have an idea about, is the 85 plus age category is the fastest growing age category in America today. And I often ask when I'm doing trainings, when I say that, and I was just doing a training with law enforcement yesterday, and I said to them, we're going to live, long. Many of you in that room are going to live well into your 80s, in your 90s, and a percentage of us are going to live into our hundreds. And I said, and isn't that good news? And of course, no one smiled or said, Yahoo, thanks for sharing. And they were like, I don't want to live that old. And it's such a stressor in our culture because of ageism that we all want to live, and I know you've said this to yourselves too, you want to live a good long time, but we don't want to see that a good long time in this day and age is living well into one's 80s. And so we have to be particularly thoughtful about people who are in their 80s and 90s. Next slide, please. And so when it comes to suicidal risk, as I said earlier, depression, whether bipolar or unipolar, is a risk factor for death by suicide. Dysthymia, which is a milder version of depression, is also a risk for suicidal ideation, schizophrenia, panic disorders. There's personality disorders. So really, that's why I wanted to just introduce mental health issues for us, because, mental health issues that are not being treated appropriately, can evolve and be correlated with suicidal ideation, and particularly depression or anxiety. Next slide. So suicide risk cannot be predicted from just any one factor, and predicting suicide is very difficult. So, of course, that's not going to be the role that we play, but what we want to do is to notice people's behavior, notice their thinking, notice their, sleeping patterns, noticing their eating patterns, noticing any change whatsoever, so that we can be able to identify people that may be at risk. The most important issue in adult services is to make certain that we can make a referral, in connection with your supervisors or with people at your facilities that you're responsible for. I just think it's really urgent that we really pay attention. Next slide. And so if somebody is, and Natasha might go into more detail about this, and I'll just briefly say, because the clock is ticking and I want to be sensitive to time. So, if an older person is talking about suicide, that's something that we want to pay attention to. If they are saying, I want to tell people that I don't want to live, we need to be aware of signs of hopelessness, and to be able to notice if they are giving away possessions, to staff or, people at the facility. Have they attempted before, and is there evidence of self-injury? Next slide. And so what we really want to do in terms of any intervention is that we've got to be able to listen. We want to be honest with our older clients. I think it's important that we let people know that we care about them, that they matter. Ask them directly if they are thinking about suicide. We need to be direct with them, and let them know that we really care about them. And I think really most importantly is let them know that we really want to stay in communication with them, and that we care for them, because that will counter their feelings sometimes, which is they feel alienated, they feel isolated, and what they'll often say is that I'm a burden to you, or I don't feel like I belong. And when we hear that burden and not, that thwarted belongingness, we know that the person is thinking about death. And for social creatures as we are, we're hardwired to connect. And if simply because we have more birthdays than other people, that we start slipping into isolation, I think it is so important that we really do everything we can to stay in contact, but keep reminding them that I will not be better off without you. You matter to me. Next slide, and then that will be my last. And I just wanted to, and there's some other slides here in terms of end of life concerns, and I think, this is where we have trouble again with people being able to talk about, finding vocabulary for maybe their fears about dying. I think it's Dr. Atul Gawande said in his book, Being Mortal, there are two unfixables, aging and death. And in an ageist society and a death-denying culture, we often inhibit people from sharing how they feel about these just normal parts of the aging continuum. And so I really encourage all of us to learn as much as we can about mental health issues that affect older people, with a particular focus on suicide prevention, intervention, and response. Thank you, Katie, for forwarding the slides, and I'll certainly be on the line if there are questions at the end. Thank you.
Thank you, Dr. Arbor. And next we have Jamie Freshy. So Jamie, if you unmute your line, I will get to your slides and you're good to go.
Thanks, Katie. I want to thank you and the National Ombudsman Resource Center for allowing me to speak during this very important webinar. I think a very important topic. I personally want to thank Dr. Arbor for everything he has taught us in Illinois on the subject, and we certainly appreciate the opportunity to share what we've done in Illinois. So you can go ahead and move to the next slide, Katie, and I'll go ahead and get started. I wanted to give the folks a little background about why we decided to come up with a protocol. First off, we pretty quickly recognized the problem being that we didn't have an existing protocol when I received a call from an ombudsman, very concerned, of course, 4:30 on a Friday, always, with a resident who was expressing that she was going to commit suicide. And so while many of us have common sense, it is a little bit difficult if you don't have a protocol or policies or procedures in place to follow, to know if you're asking and doing all of the right things. And so once that hit us, we went ahead and moved forward with doing some research to figure out where we needed to start. And by the way, that resident is fine and did not attempt suicide, and we worked through it. But back to the research, what I did was always, I check with the ombudsman first to see what they have, because I'm not a fan of reinventing the wheel. And what they had was a risk assessment done, completed by Dr. Susan Weary, which we use. That's the foundation of our protocol and our risk assessment. But I also reached out to other resources, all other state ombudsmen, and no one that responded had any sort of policy or protocol on this particular topic, because, when you start to research suicide, as Dr. Arbor pointed out, you're going to find a lot of information for younger individuals, not necessarily individuals who are aging, most of the population that we work with. And it's different. And the other piece of it was that I found quite difficult was the only thing I found related to the ombudsman was at the Resource Center with Dr. Weary's risk assessment that had anything to do with what does an ombudsman do in these circumstances, because our role is resident directed. And we just didn't find anything else out there. One of my colleagues, Dr. Carolyn Peck, is a professor of University of Illinois at Springfield, and she gave me Dr. Arbor's name and contact information, and I reached out to him. So it was an effort pulling from different resources in order to get what we're going to present to you today. Okay. So what we did was several tasks had to be completed. We were already in the middle of revising our policies and procedures, and quickly determined we needed to add a new section in our policies and procedures with a guide for ombudsmen when residents threaten suicide. We also developed what I don't know, it's a kind of a pocket guide, I guess, and it has the entire protocol on there, so that, and it's only for ombudsmen. So it's when ombudsmen are out in the field, they should carry it with them at all times. It's a small trifold, and as we go through, I kind of share but all of the protocol is on there. I'll share with you what is on there, and I believe that it is part of your handout in this particular presentation too. So we developed that. It's in our policies and procedures. And then we put together webinars to educate every ombudsman in Illinois about the new protocol and what's expected. We also invited Dr. Arbor to Illinois for a full day presentation and opened it up to all ombudsmen so that they could learn more about individuals who may be considering suicide or are depressed, have suicidal ideation. And it was really quite an eye-opening presentation and wonderful. And finally, we added a module to our required training for our newer ombudsmen that's specific to the protocol, so that we would be assuring that every ombudsman was trained on this particular subject. Okay. So our purpose was to give ombudsmen a tool, steps to take when faced with a resident who verbalizes suicidal thoughts. We've all heard residents say comments such as, "I wish I were dead," or "I'd rather die than stay here," "I'd be better off dead." We've heard those kinds of things from residents, and the question is, what do I do with that? And so we've given them this tool. Okay. Frustration versus suicidal ideation. When we work with individuals who are in long-term care facilities, and as I was listening to Dr. Arbor's presentation earlier, I kept thinking that the individuals that we're working with have experienced significant loss, do have health problems. There are reasons that they're in long-term care facilities, and so my thoughts were that we're really dealing with people who are likely at possible risk of having suicidal ideation, but we also deal with people who are just frustrated with their situation. Suicidal ideation is wanting to take your own life or thinking about suicide, and we want to make sure that ombudsmen always take these comments seriously. Okay. And what we did was, and again, using Dr. Weary's risk assessment, is asking questions. And I always preface in my training with the ombudsman, we are not clinicians. It is not our job to do a clinical assessment of an individual. That's not what this particular tool is about. And it's important to maintain the knowledge of what our role is as the ombudsman. At the same time, we have to understand what's going on with the resident. So is the person thinking of taking his or her life? How likely are they to act on those thoughts? And does the individual have a plan and also have the means to carry out their plan? So you're going to have to ask some of these tough questions in order to figure out what to do next. Okay. It's important for ombudsmen to realize that you are not responsible for making the final determination of suicide risk or for single-handedly protecting a person from his or her suicidal thoughts. But it is your responsibility for asking the appropriate questions and making an appropriate referral. I think that this is one of those topics. It's very difficult to talk about. It's very difficult to be in this situation. And part of the reason is we start to think about how are we going to feel when we walk out that door and something bad happens to the resident. Are we going to do that I should have, I could have kind of a thing? But it's important. It's one of the things that Dr. Arbor taught us was that no one is responsible for making that final determination or for single-handedly protecting someone from his or her suicidal thoughts. And so we can only do the best that we can with the tools that we're given. Okay. So our basic steps are we perform a preliminary risk assessment using a standard set of questions that's provided by the office, so that would be my office, that we communicate the risk according to our protocol. We'll determine which supports or crisis assistance to involve. We assist the resident in accessing supports, and as always, discuss with an ombudsman supervisor so that the ombudsman isn't out there feeling alone in this difficult situation. Okay? So here's our protocol. You can go to the next one, Katie. There you go. So we have specific questions, and as I tell the ombudsman during training, some of the questions that you're going to see here might seem a little bit stiff, but you obviously need to put it in your own words and ask a question in a manner in which the resident would understand. So this one's pretty basic, but as we go on, you might think, oh, I don't think I would use that word, and that's fine. Again, you're going to have to ask it in a way that the resident understands. So resident discloses to you, say one of those questions or one of those statements, I'd rather die than live here. Then the ombudsman would ask, have you told your doctor or anyone else about these thoughts? So you want to kind of just start that conversation. And regardless of how they answer, then you're going to ask the next question, which is, do you feel these feelings and thoughts are a problem for you or something that you might act on? And then it goes through, and this is part of that protocol, and this is what's in the pocket guide. So you have the questions all lined out in your pocket guide, and then if the resident says no, you're going to ask this question, but if the resident says yes, then you're going to ask, this question. And again, you want to share with the resident, reminding them you're not a physician, you're not, a clinician, you're not a therapist, you're not qualified to evaluate these thoughts and feelings, but I'm glad this is something that you feel you would not act on. And then you just kind of get into it a little bit more. Is there anyone you'd like to talk to about these feelings? So you're not being dismissive, even though they said, oh, no, I would never act on this. Obviously, there's something going on. Can we be maybe reaching out and offering them assistance before it becomes a bigger problem down the road? So you're going to want to have a conversation with them. If the resident did say yes, or maybe answers equivocally, like, oh, I don't know, I'm not really sure, you're, again, going to want to remind them what your lack of qualifications are to evaluate these kinds of situations. But again, as Dr. Arbor said, you're going to express concern about the individual and let them know, I'd like to ask you a few more questions, maybe put you in touch with someone who can help you with these thoughts and feelings. Okay. The next question is, have you thought about how you would hurt yourself? So what you're trying to figure out here, does the resident have a plan? And that's important to know. So if they answer yes, you're going to find out, do they have a way to carry it out? Do they have the means? If yes, the ombudsman asks, well, what has helped you not act on these feelings? So there you're wanting to get at, what are your deterrents? Some people will say, oh, I would never do that because of my religion. I would never do that. I would never hurt my son in that way. So you want to take a listen to what some of those deterrents might be. And then you want to ask, how likely do you think you are to act on these thoughts? Okay. So here's the risk assessment. Once you've asked and answered those questions, you're going to identify the individual, and this is a non-clinical assessment. So this is just helping the ombudsman put into some kind of organizational form where they believe the individual is at in terms of suicidal risk. So low risk would be if they don't have a plan or a vague plan, but no idea or no way of carrying it out, stating no intention of acting on it. Medium risk, having a plan, but it's vague or no means to carry it out, has some deterrence, states that they have little intention of acting on suicidal thoughts. And then you have the high-risk folks where they have a plan, they know how, when, where. The plan may involve the use of a firearm. The resident has few or no deterrence, and they state intentions of acting on the suicidal feelings regardless of when and where. And as Natasha's going to talk about too, I think sometimes people don't necessarily fit neatly into these risks, but that's where your supervisor comes into play and where you have conversations with them as well. Okay, the next. The next few slides break it down. So just in the interest of time, we can go through those. Katie, you can go to the next, to the medium, and then to the high, and then the next. So once you've determined if somebody is a low, medium, or high, then we have additional actions or questions that you can ask the resident. So if they're low risk, again, we kind of already talked about this. You're going to ask if it would be helpful for you to talk to someone, and if you can help arrange it. Is there someone with the staff that I can talk to let what you're dealing with? Are you anyone in the facility that you trust, or is there a family member? You want to try to get them some help. Of course, we always, as ombudsmen, we need you to document your contact and the determination of risk, but that will come. But you will always seek permission to talk to anybody before you would do anything. There's no difference here. We still would need resident consent to proceed to assist the resident in any manner. Okay, we can move to the medium. Oh, sorry, we're still low. You would want to advise the resident to tell someone, ask the resident what additional supports they have or could use in their life. We give them the friendship line that Dr. Arbor talked about. We give the resident our contact information, and if they don't give you permission to disclose the nature of the conversation, we can't do it. And then our protocol is to discuss with your ombudsman supervisor as soon as possible, or at least within the work week. Okay, next. So medium risk, again, you're going to express your concern. I understand from what you've told me that these thoughts of suicide are a problem. I think it would be helpful for you to see your doctor or a mental health professional. Let's ask staff to schedule an appointment with your doctor now. So you still need permission to do these things, but you're phrasing it in a little bit more direct manner because of the medium risk. Again, you're going to need to seek permission to talk to anyone on their care team or family. Ask the resident if they're willing to ask the facility staff to schedule a doctor's appointment. Okay, next. You want to facilitate a referral. So before leaving the facility, the ombudsman should try to have the resident talk with staff and offer to accompany the resident to the meeting. If they're unwilling, ask them if they have an alternate plan. Sometimes they'll come up with a good plan that you both can be comfortable with. Provide them with a friendship line number, and explain what the friendship line is, by the way. You're going to want to, again, give the resident your contact information. Can't talk to anybody without the resident's permission or disclose the nature of your conversation with anyone, unless you're told that you can by the resident. And in this case, for medium risk, in Illinois, the protocol is to talk with the regional ombudsman or the office as soon as possible, within 24 hours, but no longer than 48. Okay, next. So the high risk, we give the questions and the statements. Again, I'm concerned about you. I believe you're at risk for hurting yourself, and it's important that we get proper medical attention for you. Again, do you have a mental health counseling call? Should we ask the nurse to call your doctor or the crisis clinic? Same kind of steps. Tell the resident the concern for being at risk of harm, and let them know that you believe that additional assistance is necessary. Okay, next. You're going to seek permission to talk to facility staff, medical personnel, family line, give them the friendship line, and assist with making the call. Advise the resident of the need to talk with the nursing staff, and if the resident refuses, then the ombudsman is going to call the local crisis service or the Center for Elderly Suicide Prevention's warm line to discuss the situation and to help determine what the ombudsman's next steps should be. The ombudsman should then discuss with the regional ombudsman or the state ombudsman before leaving the facility. Okay. When a resident is high risk and has also threatened to harm others, well, if the resident threatens to harm others, you're going to immediately report to the person in charge of the facility, your immediate supervisor, and the state ombudsman, because sometimes that threat of harm does cross over to others, as we've indicated before, and we want to make sure that we're not putting others in danger or at risk either. Okay. And so we usually just kind of state that the guidelines and protocols are intended to provide direction, but should never be used as the sole determinant. And we have to allow ombudsmen to use good judgment in these situations and recognize that all situations are different. And, you know, we try to give them as many tools and support as we can, but at the end of the day, you know, we just wanted to give them something to fall back on should they be in this kind of a situation. And that's, I believe, it for mine. Man, I'm never short. I had 2 minutes to spare there, Katie.
Thank you, Jamie. And next we have Natasha Belli. Natasha, you can unmute your line and you're ready to go.
Okay, thank you. My name is Natasha Belli. I'm the Regional Ombudsman for DuPage County. And I was asked just to kind of talk about the practical use of the tool. I've been an ombudsman for a long time, and before, you can go to the next slide, sorry. Before we had the suicide protocol, I had had multiple residents over the course of my work as an ombudsman express threats of suicide. And those cases really stick on your mind. They stay with you. And I think before, we always, regardless of having a protocol or not, took residents' threats of suicide seriously. We would ask the same sorts of questions and ask resident about whether or not they had a plan. We would ask them if they had talked to anyone about their feelings. We would also ask for permission to talk with staff. And then we would inform the resident of their rights and different options, as well as what the facility may choose to do once they find out that the resident had made that threat. And more than likely that meant they were going to send the resident out to the hospital. But prior to the protocol, a lot of the situations were very different each time, and we weren't really sure how far the ombudsman was supposed to get involved. We weren't really sure what our role was as an advocate, especially since we were resident directed. Next slide. So for the ombudsman, when a resident threatens suicide, not only is it stressful for the resident, but it was also for the ombudsman, especially for a newer ombudsman, and maybe this was their first time they've had a resident express wanting to harm themselves. And if the resident did not give us consent to talk to the staff, ombudsman at times also felt really unsure of how they were supposed to handle the situation and felt like, are they responsible if the resident acts on that threat? So for my program, prior to the protocol, when a resident threatened suicide, my ombudsman staff were always to call me so that we could kind of talk through that situation so they didn't feel like they were alone. Next slide. So what I thought I would do is share with you an example of a case that we had after we received the suicide protocol from the state office. Since the implementation of the protocol, we've actually used in my office the protocol about 4 different times. In this case, we had an open case with a male resident of a skilled nursing facility who was in the facility under a VA contract. This resident had been involved in many of the sweetheart scams online. He had given away thousands of dollars to many different women through Facebook that he had befriended. He also had many bill collectors calling him because he had shared his personal information with these women, and then in turn they'd opened credit cards in his name and charged up thousands of dollars of debt. And the main reason at the time during this case the resident did all this was because he felt extremely lonely, and he thought by giving women this access to his money that they would befriend him and he might not feel as lonely. And so throughout the case, next slide, during one of the ombudsman's visit with the resident made a comment about wanting to end it all. He, at the time, had all these creditors calling. He didn't have any money in his account. He just kind of felt very defeated that what he thought was going to happen with this woman wasn't happening. And so when he made that statement that he wanted to end it all, the ombudsman asked the resident what this meant. He discussed that he wanted to die. She asked if he had a plan, and then the resident stated he did have a plan, and his plan was to wrap his call light around his neck and to continue to pull on it. At the time, the ombudsman asked if he had told anyone about his feelings, and the resident had stated he had not, but stated they don't care, meaning that the facility didn't care whether or not he was feeling this way. So at that time, what the ombudsman did was she pulled out her guide that we are to carry with us in the facility, and she started using the protocol. So she immediately wrote down the friendship line number for the resident and offered to call it with him. Next slide. The ombudsman, she also asked permission to alert the staff of his feelings so that they could arrange for someone to come in and talk to him. The resident did not give her permission to do that or to notify the staff. She also asked permission to notify his VA therapist. Again, the resident did not consent to that. And the resident had stated he did not want the staff notified because he knew that he would be sent out to the hospital, and he didn't want that. In part of the case, there had been threats of discharge previously for other issues, and so he was truly concerned that if they sent him out to the hospital, he may not get to come back to his home. The resident had also stated that he had made comments like this before, and so when the ombudsman asked him about whether or not he would act on his plan, he continued to adamantly state he would not act on the plan. The ombudsman then also discussed other options with the resident, things that might make him feel less lonely or more involved in the facility, things like attending more of the activities that were not only offered through the facility, but also through the VA. Next slide. So after the ombudsman had asked some of the questions from the protocol, she then kind of looked at the action steps and then contacted me while she was still at the facility. We talked about what the resident had discussed with her, and we kind of determined that he fit in the low to medium risk because he had a plan. He was able to carry out that plan, but he also had no intention of following through with his plan. And so following that, the ombudsman was in contact with the resident by phone and through face-to-face visits following his statements, just because we were concerned about him as a resident, but also because the ombudsman had a relationship with him through her casework. We did find out that the resident did follow through with making an appointment with his VA counselor. He also became more involved in activities through the VA, and he expressed because of that he was feeling less lonely. And he did express to the ombudsman that he was glad to have the friendship line phone number. That was something that we never had before to offer residents, and it was nice. You know, he said he appreciated that the ombudsman gave that to him. So next slide. Our program, you know, we really do feel like because all the ombudsmen, including our volunteers, are required to carry the pocket protocol with them while at the facility, the protocol really provides the ombudsman with questions to ask the resident and then action steps to follow, which has been really helpful, not just for the ombudsman, but I think, you know, too, for the resident, just due to how stressful a situation like that can be. And the friendship line gave the ombudsman an immediate resource to give to the resident that we did not have before. We also feel like the protocol has given the ombudsman more confidence and support. They no longer feel like they're the only one out there by themselves. They can refer to the pocket guide. And it's given us a better understanding of what our role as an advocate is. We're no longer feeling like we're the only one out there and we have all this information and we don't know what to do with it. That's kind of all I had. So I just wanted to thank everyone for allowing me the chance to kind of give our experience.
Thank you, Natasha, and thank you to all three of our presenters. So before I present some resources, I wanted to ask the same poll question that we asked earlier in the webinar. I wanted to ask it again to just gauge if this webinar has helped to increase your understanding. So let me launch that. So the question is, what is your comfort level in handling a situation when a resident threatens to harm themselves or commit suicide? So I'll just give everyone a minute to answer. Okay, I'm going to close this. So it looks like most did have an increase in understanding and might have picked up a few useful suggestions if you encounter the situation. So 61% said somewhat comfortable, 37% said very comfortable, and only 2% said not comfortable at all. So that's excellent. So I wanted to present a few resources. The first is the NORC website. All of the resources that I'm going to mention are all located on the NORC website, and you can get there by visiting ltcombudsman.org. And within the website, we have a mental health / mental illness issue page, and all of the resources are on this page. You can get to this page by clicking issues at the top, and then it's organized alphabetically, so just click on mental health. And there's a link on this page to all the Illinois Ombudsman Program materials that they created. And the webinar materials.
Katie, I'm sorry, we're seeing the quick poll.
Oh, I'm sorry. Are you able to see my screen now?
Yes, thank you.
Okay, sorry about that. So this is the mental health issue page. So I was saying that the Illinois Ombudsman Program materials are on this page, as well as the webinar materials will be on this page. And this is where all of our resources are located related to this topic. And this is the pocket guide that Jamie mentioned that was created by the Illinois program. This resource includes action steps for ombudsmen to take if they encounter a situation where they recognize a resident that might be suffering from mental illness, and this is on the mental health issue page.
So, Katie, can I just explain it a little bit?
Oh, sure.
If you go back.
Yeah, let me go back.
So right above where it says action steps, that actually folds down, and then it's a trifold. So it's pretty small. So when we say pocket size, it is. We didn't want anything to look super obvious or bulky or cumbersome for the ombudsman, and so that was kind of the intention with the size of it. And of course, we color coded it so that you can follow the low risk, the medium risk, the high risk steps. So anyway, I just kind of wanted to describe that a little bit. And it is on one sheet. It's the two-sided, so it's easy to carry around.
Thank you. And again, that's on the mental health issue page on the NORC website. And then we have this reference guide. And this reference guide is for ombudsman program practice to provide an overview and key points for working with individuals with mental health conditions, as well as additional resources for more in-depth knowledge to improve ombudsman skills. This resource was recently updated and is also located on the issue page. And then finally, we have this toolkit, which was produced by the Substance Abuse and Mental Health Services Administration. Its purpose is to equip senior living staff with resources to promote mental health and to prevent suicide and encourage active participation among residents. So this toolkit includes guidelines for integrating suicide prevention into ongoing programs, hands-on tools, and training manuals. Okay. So at this time, I'm going to turn it over to Amity. If we received any questions in the question box, you can type, Amity will go over them now, or you can type them if you would like. Thank you.
Thanks, Katie, and thanks to all of our presenters. We do have several really good questions, so we're going to try to get through as many as we can. The first one I wanted to ask, because it actually kind of follows up how we asked the second poll question about that would indicate comfort level in responding to someone that expresses thoughts of suicide. So I thought it would make a good conversation to get started. The commenter said they struggle with the idea that if someone is having suicidal thoughts and said so, but did not give me permission as an ombudsman to talk to anyone about it, how I could personally be okay with that. I know I can give them referral information and resources, and we need to respect their rights and confidentiality. Basically, what do others think about this, and how do they handle this? And I thought it would be great for maybe Dr. Arbor to talk a little bit about that, and because I know, Jamie, you mentioned that he did talk about that during your training, kind of dealing with that feeling, and then maybe Natasha as well. So feel free to jump in and unmute your line to respond.
Well, I agree. I think that is a really important question, and I wanted to acknowledge those in the poll who still were uncomfortable, because I think this is really a challenging topic. And for many of us, the word suicide is a very triggering word, and can make us feel very concerned about our capacity to kind of hold that space with people and even to ask these questions. One of the things that, certainly with our volunteers when we do our training, and again, as you know, I've been doing this for a very long time, what I say to our volunteers is we have to be very thoughtful when an older person says to us, there's something I want to tell you, but you have to promise that you will keep it to yourself. What I say to our volunteers is, do not get hooked into that kind of promise, because they might tell you something that is really something that we must share with someone else, such as I'm being abused or I'm thinking about killing myself. I think we have to be very, very thoughtful about that, because to carry that around and making that promise that I won't say anything before we hear what their statement is, I think puts us in a very, very vulnerable and awkward place. And I've had, over my, work career, I've had volunteers who made this type of promise and then really had a very hard time managing it afterwards, and were just very worried about the person. And I just think it's a promise that we cannot agree to. And I let people know that. But what I also tell them is, please feel free to tell me whatever it is you want to tell me, because I can see that it's important. But I cannot promise if you are, and I let them know this, if you are going to say you're going to harm yourself, that's I really want to help you, and that's going to be very difficult for me. And my experience has been that older people, if they really feel that you care about them, I go back to that, and I know Jamie had highlighted that too. I think you have to really remind people that this is very serious, that there are some agreements that I cannot make, and I think Jamie highlighted some of those. Um, and this is where I think it is so important to be able to talk to your supervisor or others who can help us process this, because I think we have to also be aware of self-care when we work with a vulnerable population of older people. There are some challenging aspects to it, and that's why I was glad, Jamie, that you went through that protocol, because I think there are really important things in there that can help us feel better about these kinds of situations. But my bottom line is, I really encourage people with older adults, when they say, I want to tell you something and I want you to keep this private, make a promise to do that. I think it's really important that we don't get caught in that kind of a situation.
And I just kind of want to piggyback on what Dr. Arbor says, and I do think it's important. Ombudsmen are bound by strict confidentiality, but we do talk to our supervisors about the situation. And it could be something so serious that it gets to the state ombudsman, and I'm making a determination as to whether or not that needs to be shared with a professional who could assist the resident. So thank you for saying that, Dr. Arbor, because I do think it's important to not, we train ombudsmen to not give false promises,
right,
in any respect, but I think developing that trusting relationship, you don't want to break that with a resident. So I don't know, Natasha, do you have anything to say about the question?
No, I mean, I definitely agree. It is the first time you have a resident express that they want to harm themselves and they tell you, I don't want you to tell anyone. I think building that relationship and that trusting feeling with the resident has helped me in the past, where the resident, when I expressed to the resident that I was really concerned about them and that I really felt like they needed to let the staff know so that they could get the help that they needed, and that, as an advocate, that I would, respect their decisions, but there were times that, it was uncomfortable, and being able to kind of discuss it with my supervisor helped. And I think the protocol really kind of made it a little bit easier, so that you're not leaving the facility feeling like you're the only person that knows that this resident has expressed these concerns and they won't let you do anything about it. In the cases that I had previous to the protocol, I only had one resident that would not let me talk to staff. The other residents would allow me to let the staff know, and I think some of that is because I had built a relationship with them over time based on the other situations we were working on, and they felt like they could trust the ombudsman to help them through that situation. A lot of it had to do with concern about being sent out to the hospital and not being taken back. But that was something we do spend a lot of time talking about. You know, if a resident is making a comment like that, that they have to understand that everyone will take that seriously, that they can't joke around about it because the facility isn't going to find it to be a joke, that they will send them out. And as much as we don't want them to do that, they're going to follow what they have to do to protect the resident.
See, and I just want to agree, Natasha. I think that this is serious, you know, and I think we have to make sure that our residents really understand that. And the second thing, as you said, and I think that's so worth repeating, is that, and I am your advocate. I want to help you. I'm not going to abandon you. And so let's talk about it openly, you know. And then I think we have to respect, as you were saying, confidentiality. But I see a difference between confidentiality and promising. And I think we just have to be really, really thoughtful about it.
Thank you all. This is Amity again, and before we move to the next question, I just want to circle back and touch on a little bit of what you already shared in response to that question, and just remind everybody that, as you all stated, this is really sensitive, really challenging, and Ombudsman, you deal with sensitive and challenging things every day in your work, but this in particular is especially challenging. So I want to reiterate how important it is to have state ombudsman program policies, procedures, and a process for handling this, because it is hopefully unique. You hopefully won't encounter this very often, and hopefully you certainly won't encounter those that fall under the high risk category. So I just want to refer back to that, the Illinois Policies and Procedures and the Pocket Guide. When you look, someone has to meet high risk in order for someone to be contacted, for the ombudsman to contact the staff and let them know, which means they have a plan, they don't have, that involves a firearm, potentially helping others. So that's a very unique situation. So I just wanted to be really specific that this, because obviously there are very clear requirements for ombudsman disclosure. So just wanted to kind of circle back to that and close that loop, because I know there are some other questions that came in the chat feature about confidentiality in those situations. So hopefully that addresses that. There were also several comments that came in, and I'm going to try to combine them because just for sake of time. A lot of concern, and we don't just hear this in the chat feature, we hear this from ombudsman programs across the country, that nursing homes simply aren't staffed or trained in responding to residents that really need mental health services. And so some of the questions that came across were, why has there been such a decrease in mental health services? Several resources, local or regional resources, have closed, and emergency rooms are just that, emergency rooms, and they'll level off meds and send them back. Or don't most nursing homes just prescribe another medication for depression because they don't have the proper mental health services or access to those in the community? So that's a big question, but I was hoping maybe Dr. Arbor or Jamie or Natasha, you could share an example of when it works, in addition to the friendship line. Do you have any examples of when facilities do have access to proper services, and maybe some positive examples of that being available in these situations?
Well, what I would say, first of all, is that I really empathize with those of you who are in those situations where there doesn't appear to be anything other than emergency rooms that are there for the resident. What I've seen, you know, in different sections of the country where the nursing home or the facility has a psychologist or a psychiatrist who is available, might be on call or that sort of thing. or nursing staff. I think nursing staff are often underutilized when it comes to mental health, but I think they're very competent. And so I think that where there is access to someone in mental health that has a relationship with the residents, I think that I've seen that model be very helpful because there's someone that can be contacted who knows the facility, who knows the structure of the facility. That I think that can be very workable. But to the other question that the residents were or the participants were raising about what's happening in terms of mental health and the lack of mental health facilities, I think that that really speaks to disparity. And as Jamie had mentioned too earlier, is that there are a lot of options for younger people, particularly youth who might be ideating suicide, but there is disparity between that group and then older adults. And that is, I think, a grave concern that our country has to really find a way to figure that out.
In Illinois, we have facilities that are supposed to specialize in mental health, but I would say that most of those facilities are our younger crowd, and I don't see the mental health needs being addressed in what you would perceive as a traditional nursing home, other than maybe just through medication. And I don't believe that that's a holistic approach. I know, Natasha, you've got several facilities in your area. I'd like for you to maybe speak on that, but I agree with the person asking the question that it doesn't appear to be in Illinois an appropriate level of services for our for individuals with mental health that are living in long-term care facilities. Natasha?
I agree. I mean, I think the we have 4 facilities here in DuPage County that specifically take residents with mental health issues. And in the same cases as in a regular skilled facility, as soon as they threaten to harm themselves, their first reaction is to send them out to the hospital as well. So I don't really see a difference in how things are handled, even though they're a facility that is supposed to specialize in helping residents with mental illness. Their first reaction is always to send them out to the hospital, and then when they get back, they continue with working their level system that most of our facilities have. So it is quite sad.
Thank you all. So I'm going to try to get in at least 3 more questions. So 2 are kind of yes or no. The first one is the friendship line only available in Dr. Arbor, your state, Illinois, or is it a nationwide number? Or if not, are there similar numbers in each state and maybe a network that we could connect our ombudsman network with those numbers?
Well, that's an easy one to answer, is that we are nationwide. Actually, 50% of our calls are generated outside the state of California, and 50% of our calls are generated within the state of California. So people anywhere in the country can call the friendship line.
Great, thank you. And I apologize if you already mentioned that and I missed it. So thanks for reiterating that.
Sure.
Another question kind of linked to sending the resident outside of the facility. The question is, many facilities refuse to keep residents that have exhibited suicidal ideations. How does this potential unintended consequence impact what is shared with the resident or their legal decision maker for the resident and or facility staff, if at all? Have you, Jamie or Natasha, have y'all experienced that in any of these cases?
I have in the past, been able to work with the facility to kind of talk with them to ensure that the resident was able to come back, just kind of discussing, with them what's in their care plan and how they've worked with the facility in the past. and just so that the resident on top, when they're already having feelings of, you know, depression or anxiety, that adding that stress of wondering whether or not they'll be able to come back to their home or not, you know, having that conversation with the facility that this is their home and trying to get them to understand that the resident is just needing, you know, maybe more added extra support than they usually would, has at times worked. I mean, there are going to be facilities that once a resident makes a comment like that and they decide to send them out to the hospital, they're just not going to want to deal with them. But we try to advocate for resident rights to get them back into that facility as soon as they can.
The thing that we have to keep in mind as the ombudsman when we're working with these situations is that residents have committed suicide at facilities, and those facilities that have had that happen are, we mentioned it earlier, that it affects everyone. And so sometimes facilities are just scared, that maybe recognize they don't have the resources and they're afraid. Certainly not making any excuses for them, but I'm glad, you know, when Natasha's saying that she worked with the facility and explained them, it really does take a whole lot of advocacy on our part on that. But, you know, we don't have crystal balls. We can't see into the future. But yeah, that's certainly been a concern of facilities not wanting to keep residents who are who may be experiencing suicidal ideation.
And
Thank you.
Can I just add very quickly to that, because it makes me so angry. And I agree with both Natasha and Jamie, but I really see institutionalized ageism and again, institutionalized stigma. People do recover. See, that's the thing we have to remember. I know there's myth out there that if somebody is suicidal, and I'm sure some of us have thought about that, oh, well, they're going to eventually kill themselves. And I think that's part of what I was hearing in Natasha's comment about a facility that is reluctant to take somebody back. People recover. When there is good intervention, people recover. They may never again in their life think about suicide death. They might think about death, of course, if they're 80 or whatever, 90, but I just want to emphasize that people recover. They get better from depression. They get better from anxiety. You know, intervention really does work. So forgive me getting on my little platform there.
No, thank you for that.
I'm glad you did, and couldn't agree more that connecting individuals with the proper services that they need is critical. Which actually reminds me, and we don't have time to talk about it in today's webinar, but as kind of some homework after today's webinar, if you could, especially for nursing homes specifically, look at the revised nursing home regulations as well as the surveyor guidance and the SOM, the guidance to surveyors. There's a lot more guidance than there has been before about supporting residents with mental and behavioral health needs. So, you know, these facilities are required to provide individualized care and connect those residents with the services they need, even though it may be challenging depending on where your area, if you're in a rural area or just lack those resources, but that is required of them to do so. So check out that regulatory language and that guidance. I think it would be really helpful in your advocacy. So last question, because I know that Katie wants to wrap it up and highlight one more thing. Have you or Natasha received any pushback from your volunteers about implementing this protocol? And if so, how did you handle that?
I'll answer first. They may be more honest with Natasha, but on my end, I've heard honestly nothing but thank you. We appreciate having this tool. We weren't sure what to do before. Now at least we have some kind of a guideline to follow, and it's better than not having anything at all. So I don't know, Natasha, have you gotten any?
No, I agree. I think, you know, even for me, I was a little hesitant thinking, okay, we're going to have our volunteers have the protocol, and, you know, is that going to be too much for some of them, or is this going to scare them a little bit? But I think having it makes them feel a little more protected or more comforted that they have something they can refer to. But they also, we really do stress with our volunteers that if that situation were to come up with them, that that's something they need to immediately call either myself or a volunteer coordinator, so that then we can assist them since they are volunteers. And we do try to explain that so that they feel comfortable and not scared now that they have this protocol, that this is just going to start happening to them. But I think so far, you know, they've been very happy to have it.
Good, good. I thought that would be the answer, and just want to remind everyone, even though I'm sure you're already doing this in practice, that in working with volunteers, they may have certain topics, maybe sexual expression or other issues that they don't feel comfortable with. That's why there are supervisors. Just always encourage them to be open and honest if they encounter something they don't feel comfortable dealing with, and refer it to whoever their supervisor is. So thank you all for your responses. Katie, I'm going to turn it back to you.
Thank you, Amity, and thank you everyone for your questions. I just wanted to mention that if anyone has any success stories on this topic, or if you've experienced challenges or have materials or additional questions, please email us at ombudscenter@theconsumervoice.org. We would love to hear from you, and we'll be sure to do our best to provide any additional information if you would like any resources. And with that, I wanted to thank all of you for joining us today to discuss this important topic, and thank you to our presenters for taking the time to share your knowledge. We appreciate all of your work. And so, as I mentioned, all the materials will be on our website this week. And if you have any additional questions, please email us. So thank you. Have a good rest of your day.
Thank you. Bye.
Thank you.